All right. Welcome back to NeuroClarity, the podcast where we break down complex world of clinical neurology into sharp, memorable lessons. Whether you're commuting, preparing for the boards, or just love a good clinical puzzle, you're in the right place. Today, we are tackling four high-yield neurology questions, but more than that, we'll explore the why behind each answer so you can walk away understanding not just what's correct, but why it makes sense. Let's dive in. A 42-year-old woman presents for evaluation of headaches and is found to have a left MCA bifurcation aneurysm. The patient asks about risks. Which of the following is incorrect? A. Patients with previous aneurysmal rupture have a higher risk of subarachnoid hemorrhage. B. Smoking is a risk factor for aneurysmal rupture. C. Anterior circulation aneurysms have a higher risk of rupture when compared with posterior circulation aneurysms. D. Patient's age should be taken into consideration when formulating the management strategy. And E. Uncontrolled hypertension may be a risk for aneurysmal rupture. What do we think? A, B, D, and E are absolutely correct. Option C is the incorrect statement. Let's unpack this. Intracranial aneurysms are outpouchings in vessel walls, and their rupture can lead to subarachnoid hemorrhage, which is a neurological emergency with high mortality. For posterior circulation aneurysms, those in areas like the basilar or vertebral arteries actually carry a higher risk of rupture than anterior ones, even if they are smaller in size. This makes them especially dangerous and more likely to require earlier treatment. Here's how the rest of the other options hold up. 1. Previous rupture absolutely increases the risk. If you've bled once, the wall is structurally weakened and the chance of bleeding again is very real. 2. Smoking contributes to vessel wall degradation and inflammation, which is another major risk factor for rupture. 3. Age matters a lot. Younger patients might tolerate conservative management of small unruptured aneurysms better than older patients. And 4. Hypertension is a big culprit. High blood pressure damages vessel walls over time, and this increases their risk of rupture. To recap, posterior aneurysms have a higher risk of rupture, not anterior aneurysms. Smoking, hypertension, and a previous rupture point towards red danger signs. Patient's age and aneurysm characteristics should always guide your decision. So, option C is our answer. Next question. Question 35. A 59-year-old right-handed man presents with neurologic deficits. A brain CT scan is obtained and is shown in figure 2.11. Let us take a look at our brain CT. Which of the following manifestations would not be seen in this patient as a result of this lesion? A. Right homonymous hemianopia. B. Anomia. C. Alexia. D. Visual agnosia. And E. Expressive aphasia. So let us take a look at our brain CT again. What do we see? Generally, I like to orient myself whenever I am looking at the brain CT. So this is a non-contrast CT of the head at the level of the basal ganglia. The scan is of adequate quality without significant motion or beam hardening artifacts. I can see the head of the caudate nucleus anteromedially. Here is the lentiform nucleus composed of the putamen and the globus pallidus. I can also see the internal capsule which separates the caudate from the lentiform nucleus. Over here we have the thalamus bilaterally, and right here we have the insula which is lateral to the lentiform nucleus. I can see the sylvian feature in here, and something strikes me as odd here. There is an area of hypodensity in the region supplied by the left PCA precisely at the occipital lobe. So this is a left PCA stroke hitting the occipital lobe, the part of the brain that processes vision. And what do you expect to see based on the clinical findings? I expect to see one, right homonymous hemianopia, which is a classic finding. Damage to the left occipital cortex causes loss of vision in the right visual fields of both eyes. I also expect to see alexia. If the infarct involves the splenum of the corpus callosum, the patient will not be able to read, especially if they have alexia without agraphia, meaning they can write but they can't read. Also, they may have symptoms which include anomia and visual agnosia. These are signs that visual processing and naming pathways are disrupted. A person can see but can't recognize or name objects. But expressive aphasia is linked to Broca's area in the frontal lobe, nowhere close to the occipital lobe. Quick recap. Broca's area is what Brodmann's area? Did you say area 44 and 45? If you said that, you are absolutely right. Broca's area is areas 44 and 45. So far so good, we've said PCA stroke cause visual and reading deficits, but no issues with speech production. We've also said that alexia without agraphia is a hallmark of dominant occipital infarct that involves the splenum. And we've said that expressive aphasia is a result of frontal lobe damage, not occipital lobe. So our answer is options E, expressive aphasia. Next question. Question 36. A 56-year-old woman with diabetes comes to the clinic with a sudden onset of vertical diplopia with limited adduction and vertical movement of the right eye. She also has tremors and choreoathetotic movement on the left side of her body. Which of the following is the most likely diagnosis? A. Right ventral mesencephalic tegmentum infarct. B. Left ventral mesencephalic tegmentum infarct. C. Right pontine infarct. D. Left pontine infarct. And E. Quadrigeminal plate infarct. What do you think? If after reading this case, what came into your mind was, oh, this is a classic presentation of Benedikt syndrome, just close this video. You really do not need it. Yes, you're right. This is a classical presentation of Benedikt syndrome, which is a midbrain stroke syndrome. Let's break it down. In this case, we see that this patient has vertical diplopia. Basically, objects look double in the vertical orientation. This highly suggests cranial nerve number 3 involvement, which is the oculomotor nerve. There is also limitation in right eye movement, and this actually pinpoints the lesion to the right. We have contralateral left-sided tremor and choreoathetosis, which means that there is damage to the red nucleus and subthalamic pathways in the midbrain. The red nucleus modulates motor coordination, and its disruption leads to involuntary, jerky, slow breathing movements, which we call choreoathetosis. So, we have a midbrain lesion that hits cranial nerve number 3 fibers, which is causing eye movement problems, and motor modulation pathways causing movement disorders. So, whenever you see eye movement palsy plus contralateral chorea, always think Benedikt syndrome. This localizes to the ventral midbrain, which has a fancy name called mesencephalic tegmentum. Can we see that 5 times? Mesencephalic tegmentum, mesencephalic tegmentum, mesencephalic tegmentum, mesencephalic tegmentum, mesencephalic tegmentum. That was a very good tongue twister. Anyways, let's be serious. Remember, cranial nerve number 3 palsy always helps to pinpoint the site of the lesion. So back to our question. We've said that this occurs in the ventral mesencephalic tegmentum and it's an infarct, and this is going on the right because the eye helped us to know exactly where this is happening. So options A is the right answer. Next question. Question 37. A right-handed patient presents with acute onset of neurologic deficits, and an MRI of the brain is obtained and is shown in figure 2.12. Let us take a look at the MRI. Oh my, that's large. Which of the following manifestations may be seen in this patient? A. Neglect of the left side of the body. B. Gaze deviation towards the right. C. Global aphasia. D. Paresis of the right leg more than the face and arm. And E. Left homonymous hemianopsia. Let us take a look at our MRI again. What do we think? Whenever we try to interpret an MRI, it's good for us to start with the basics. This is an axial DWI at the level of the basal ganglia. From here, we can see marked areas of restricted diffusion involving the left caudate head, the putamen, the globus pallidus, and this extends into the posterior limb of the internal capsule and adjacent left frontoparietal cortex. The area of hyperintensity conforms to the territory supplied by the left MCA involving both the deep perforating branches and the lenticulostriate arteries and the superficial cortical branches. As we can see, the contralateral hemisphere appears normal with no area of restricted diffusion. This is a left MCA stroke, right in the dominant hemisphere, which is likely the left side for a right-handed person. Here's what happens. Aphasia occurs because the stroke affects both the Broca's area, frontal lobe equals expressive speech, and the Wernicke's area because the temporal lobe equals comprehension. Putting one and two together, that's global aphasia, loss of both speech and understanding. Gaze deviation occurs towards the side of the lesion. So, in a left MCA stroke, the gaze would deviate left, not right. That eliminates B, so B is wrong. Right hemiparesis is expected, and since it's the midcerebral artery territory, the face and arm are more involved than the leg, which is the anterior cerebral artery territory. How about left homonymous hemianopia? No, a left hemisphere lesion affects the right visual field. Neglect is more common in non-dominant hemispheric stroke, usually right-sided stroke. So here's a summary of everything we've just said. Global aphasia means we have dominant hemispheric middle cerebral artery stroke. And in here, the weakness affects the arm and the face greater than the leg. The gaze drifts towards the side of the lesion and visual field loss is contralateral. And that's a wrap of today's episode of NeuroClarity. Here are our key takeaways. 1. Posterior aneurysms are more likely to rupture than anterior aneurysms. So, occipital posterior cerebral artery stroke give alexia, anomia, and hemianopia, not speech issues. 3. Benedikt syndrome equals to cranial nerve number 3 palsy plus contralateral chorea, which points towards a midbrain issue. 4. Global aphasia represents large dominant MCA stroke, and when you see that, think left side in right-handers. That's all for today. Do you want to reinforce your learning? If yes, try explaining one of today's syndromes to a friend, or better yet, record yourself and summarize it. That's how you lock it in. Until next time, keep those neurons firing and stay curious. This is NeuroClarity. Bye for now.